would normally do. I really appreciate you giving up your time to do this, but I thought that the main item on the agenda that we're discussing today, because of the timetable, which we'll come on to when we come to that item, it was very difficult to slot in a meeting and also the availability of people. And so we ended up with this slot. So I'm hoping that we, provided I don't want to restrict members' input. I'm hoping that we don't extend much more than I've said an hour, because some of us have also got a local area committee members meeting later on, and so we'll see how it goes. Housekeeping arrangements. I think everyone knows where the public toilets are. If there is a fire alarm, we assemble. Just remind me where we assemble, Jenny. Yeah, through the anteroom, down the main staircase, to outside the terminal. Yeah, okay. I think that's housekeeping, isn't it? We've been circulated. Everyone's been circulated with the building rules for social isolation and so on. Right. With that. Apologies. Oh yeah, so Councillor Vic Bowden. Lucy Edwards from Health Watch, unfortunately, is ill at the moment. Sent her apologies, but she has made a couple of comments on the main report, which I'll read out when we come to the item on there. So if, sorry, follow this in sequence, sorry. To identify whether there are any items, we should exclude the press and public, and there aren't any. So let's move on to anyone with any declarations of interest. In any item on the agenda? No. So can we turn to the minutes of the meetings? Well, both meetings we held on. So we go to the right page. So the meeting on the 7th was. The meeting that was any matters, just at the appointment of Talib as deputy chair. I suppose anyone any comments? No. Okay. We can accept those minutes. So, on page 11, minutes of the meeting that we held on the 14th of July. Has anyone any points of accuracy, first of all, on the minutes? Anybody think there's anything that's not quite accurate as a record of the meeting? Very quickly, then any matters arising. Right, I'll go through it page by page, and then if you want to just indicate or shout up as we get to the page. Right. Anything on page 11? on page 12, page 13, page 14, page 15, page 16, 17, 18. Emily.
Just to update on 6.5, we did circulate a letter from the CCG to all about the decision of the Children's Hospital Trust to reinstate the service until I think January 2022 to follow the proper procedure as you asked them to do. So you should all have that information. If you haven't, let me know and I can recirculate. They will also be coming to the next meeting of the committee with the consultation plan, so you'll have another opportunity to talk to them about their plans to consult on that.
Okay, thanks, Emily. Anything else on page 18? Page 19, page 20, page 21, page 22, page 23, there's nothing on page 24. Can I just say, can I apologise for the length of the meeting? It's very rare we get so many controversial items on one agenda. As I say, I'm trying to keep this very, very short. Okay. So if we accept the minutes, do we have any public questions or petitions? No, none. So we now move on to the main item on the agenda today. And I suppose it's appropriate just to, first of all, to just relate to you, as I said, Lucy Edwards from Health Watch is unable to send her apologies. So before I ask Alexis to, you'll present the report. Or is it? Right. Okay. Well, right. Sorry. I'll tell you what. Yeah. Emily's suggesting that we take the work programme because we're still waiting for Dr. Terry Hudson, who's the chair of the CCG. He's on his way, but he's just been slightly held up. So I'll hand over to you, Emily, for just update us on our discussions about the work programme.
Sure. So the next meeting of the committee is on the 29th of September. And we're hoping to bring, so the CCG will be bringing the consultation plan for the speech and language therapy issue. So there'll be an opportunity for you to comment on that. And we've also asked the Care Trust to come along to give an update on recent CQC inspections. So both on Firs Hill Rise, I think a member of the committee asked to bring that, and also they were re-inspected following the previous CQC inspection recently. So they'll come along to give the committee an update on that. We're also trying to timetable an item on primary care with the CCG to talk about the capital programme and a bit of a general update on how primary care is doing. So that's what we're working for to September, and then beyond that we're looking to timetable COVID recovery in social care and in mental health, the things that you have asked to look at. So that's where we are for kind of the next couple of months, and there's an opportunity, as always, for anyone to make any requests or suggestions now if there's anything you want to throw into the pot, so to speak.
Okay, so I'll open it up to members. Are you happy we progress along the way that Emily's described? Okay, everybody seems happy. Happy is the right word. Oh, tell him, you got your hand up. Yeah.
I believe I suggested for the dental care, it's not on work program. If it is, then it should be on, next meeting or meeting after. Is that okay?
It's on the long list of items. We last considered that in February of this year, so I was looking at timetabling that almost as kind of a year afterwards to give an annual update, almost how far have we moved since we considered that last year. So we'll look to timetable that as soon as appropriate, if you're happy with that.
Happy with that time. Ruth.
Thank you. Is the intention to determine how we place this ICS item on the work programme after today's meeting? It was raised at the last meeting as potentially a standing item, but are we to determine whether to go forward with that after we've had the discussion today?
I think if that's one of the following today's discussion, if that's one of the things that you want to suggest, then yeah, we can look at that. So yeah.
I think because things are moving so rapidly in Westminster and so on, it's likely that we want to have it. Well, we'll see after the discussion today anyway. Right, is there anything else on the work programme? Lewis.
Thank you, Chair. Has anything ever been done on work to do with the armed forces community and looking at mental health in particular and physical health? Any reports on that? I'm looking to Emily. I don't recall that this scrutiny committee has specifically looked at health or mental health with regard to the armed forces. Gary, yeah.
Yes, Chair. It's a few years ago, but through the Armed Forces Covenant, maybe if you can drag that out and have a look. But yeah, good point.
We are planning to schedule a session on mental health, so we can look to incorporate that as part of that. And I can remember the Armed Forces Covenant, so I'll have a look and I'll circulate that as well.
We'll take that back then. Bernard, yeah.
I know about 12 years ago there was an item came to council about combat stress. I don't know how far that went, but that was about mental health and the armed services and the work that it was doing. I'd also like to suggest again that we look at the contribution a healthy nature, a natural environment makes to people's mental health. I know that the Sheffield and Rotherham Wildlife Trust has done considerable work on this, and I would suggest that we actually approached somebody from that organisation to come and do a presentation and discuss the evidence base that they're providing.
Thank you, Bernard. Emily and I have discussed this, and we looked at incorporate the possibility of incorporating it. As Emily said, we're already due to have reports back on the getting back to good from the Health Social Care Trust and other items around mental health. And I've had a discussion about green prescribing as being part of that as a possibility on that particular agenda. Is that okay? All right. Right. Any other? While we're still on the work programme, anyone else want to contribute? I mean, we always have the route of email, so email myself or Emily with any thoughts that you might have. I mean, we do need to keep we haven't got an unlimited amount of time, but over the course of the council year. But feel free to email any thoughts you may have in the meantime. Okay. Right. So, having dealt with the work programme, that brings us to the main item on the agenda, agenda item 7, can I, at this outset, we have both Dr. Terry Hudson, who is the chair of the clinical commissioning group in Sheffield, and also Alexis Chappell, who is director of adult health and social care. So, I suppose welcome. Welcome, Terry. Are you ready? Are you able to present the report that we've got today and say something about it? But can I stop you there? Is he logged in? So.
Have we got something now? Okay, it's quite sensitive. I don't need to shout now, do I? I'll just start with a bit of context. I was sort of asked to come to the meeting from yesterday to fill in for an absent colleague. So I'm familiar with the contents of the report, and I think rather than go through the report line by line in exact detail, it would probably be helpful.
Well, I'll assume that members will have had the chance to have read the report.
So I think what would be helpful is to give a high-level overview of what the paper contains, and then take questions and discuss that, if that's okay with you. So thank you for inviting me along. I'm Terry Hudson. I'm a GP at Porterbrook Medical Centre in Sheffield, and as you've already pointed out, the chair of the CCG here in Sheffield. I've got some other roles that kind of perhaps give me a bit of perspective into what the paper contains that other CCG chairs may not. So I co-chair the Health and Wellbeing Board with George Linders-Hammond, and also the Joint Commissioning Committee with the local authority. And for all my sins, I'm now overseeing the change and transition process from the CCG into the new ICS. So there's sort of various different perspectives that I'll be able to give you on things, hopefully, from today's discussion. The paper itself, so back in November, early December last year, NHS England released a consultation paper, I believe it was called, or an engagement paper, which outlined their ambition to advise government on legislative reform to introduce integrated care systems to replace CCGs and essentially merge groups of CCGs into larger footprints. But beyond the world of commissioning, to also integrate in provider organisations from the NHS and to include social care into the planning and delivery of health care under the new arrangements. So that was followed up by the first white paper and then subsequent passages through Parliament, which is now, I understand, at the committee stage, and we'll see where that goes with those relevant amendments. But what the paper outlines essentially is that the integrated care systems will become statutory bodies from the 1st of April 2022, and it's a continuation of a journey towards integration that the NHS has been on since 2018. So within our integrated care system in South Yorkshire and Bassetlaw, we currently comprise of 32 organisations, which includes the 5 CCGs from South Yorkshire and Bassetlaw CCG. We're aware that there have been some developments on that, in that there will be a boundary change such that ICSs will be coterminous with upper tier local authorities It may be one authority or it may be multiple authorities. And in that respect, our proposed integrated care system from April onwards will just include the 4 CCGs in South Yorkshire, and Bassetlaw will join Nottingham and Nottinghamshire. The integrated care system itself will comprise of 2 parts. So the first part is a partnership, and the partnership is a form of committee which is not too dissimilar to a health and wellbeing board, but it will not hold statutory powers or statutory authority. And the job of the partnership committee is to bring together various different organisations from healthcare, from social care, local government, voluntary and community organisations, and over time that can necessarily be expanded into other types of organisations that serve local communities. The job of the partnership is to help develop a sense of direction, so a high-level strategy for health and care systems within the integrated care system itself. It will also advise the second component of the integrated care system, which is now being referred to as the Integrated Care Board, or in some papers you may have read it will be the NHS ICS body. They're synonymous with one another, but the new terminology is the Integrated Care Board. And the Integrated Care Board will be the statutory component of integrated care systems that will take on the existing functions of CCGs. And it will also take on some new delegated functions from NHS England. And the indication of that at the moment is that will be for all primary care services. So that will include dentistry, optometry, community pharmacy and general practice. So those will be commissioned and developed at a South Yorkshire level rather than a regional level as there have been previously. In addition to that, there will be some areas of specialist commissioning. So there's some highly complex care pathways that are commissioned nationally for eating disorders, certain types of rare cancers, and they will be delegated down into ICSs to be done at a kind of a sub-regional level rather than at the national level. The final component of some of the specialist commissioning is that the ICSs will be expected to pick up some of the commissioning for health in justice. So in and justice are separate words rather than injustice. Those are specific to providing health care for prisoners in that specific component. The ICS body itself, there's some indications that that body will have to have a designated chair, and an appointment process has been undertaken in South Yorkshire and Bassetlaw, and the chair has been appointed. There will be a chief executive, and at the moment the indication for some of the statutory membership of that is there will be a medical director, a nursing director and a finance director, plus 2 non-executives. Again, that will be awaiting some of the pending legislation on that. So what the white paper proposed and what is going through the Act as it passes through Parliament is a form of evolution back from a big system. So we're moving from 4 CCGs into a larger system, but there is a commitment that there should be the appropriate level of planning and appropriate level of delivery of care services within places. So the document refers to places. In the context, place means Sheffield. So we will, according to this plan, be moving towards 1 ICS for South Yorkshire with 4 operational places. And at the place level, there will continue to be commissioning as there is at the moment, but there will be much greater emphasis on working in partnership between health and social care, but also between commissioning and provision, and then finally between primary care services, so general practice in particular, and secondary care services, so those delivered in hospitals. And the plan is quite vague at the moment in terms of what the government are setting out, but there will be an expectation of a place-based partnership in every place. Now, they haven't defined what place means, but in the context of the journey that we're on in South Yorkshire and Bassetlaw, place is the local authority level. So we are anticipating through the journey that we've been on over the last 2 years and its continuation that we will continue to commission and work in partnership in the way that we have over the last few years in Sheffield. So the current arrangement that we have in place for our place partnership, first is the partnership itself that we refer to currently in Sheffield as the Accountable Care Partnership. And this is about developing an approach for the joined up provision of services so that people aren't being passed from one service to another and people aren't falling between the cracks between different layers of health services and indeed between health and social care services. The current operating model for that is that there is an ACP board, and we've got members from across all of our providers in Sheffield. We've got local authority representation as both a commissioner and provider of services, and we currently have the commissioner from the NHS, which is the CCG. On top of the place partnership, we've got a really what I would probably refer back to Alexis here, but quite a successful joint commissioning arrangement in Sheffield. It's one of the most advanced commissioning arrangements in England and holds one of the largest pooled budgets in England. So currently the pooled budget for joint health commissioning and some elements of social care commissioning amounts, last year the budget we signed off was for 428 million. And there are ambitions to include more in that so that we have much greater control over many areas of health and care that we wish to continue commissioning at that place level. In addition to talking about the budgetary components of it, over the last 18 months we've been working quite hard between the CCG and the local authority to develop a single health and care commissioning plan. And we signed that off earlier this year, I believe in April, but Alexis may correct me if my memory serves me right there. But it's the first time in Sheffield, and indeed the first time anywhere in South Yorkshire, that there's been one single integrated commissioning plan between a local authority and a health commissioner. So some very big steps taken there. Building on that, we have developed a health inequalities outcome framework. So rather than focusing on the contracting elements of commissioning, we are being very, very clear on what the anticipated outcomes should be in terms of improving health, but also in terms of improving, or rather improving, but actually narrowing that gap in health inequality that we've seen between various different districts within our city. And we are quite fortunate that the rest of the partnership is following suit now. So we've had a sign up from our major health provider organisations that they will follow that single One Sheffield outcome framework. Going back to the integrated care system itself, I think it's quite important to recognise that there will be an ongoing role for health and wellbeing boards in each of those 4 places, and the role of the Health and Wellbeing Board will remain the same. So that will be to set strategy at city level, and our joint commissioners and our integrated providers will follow the health and wellbeing strategy as they do at the moment. But the integrated care system will also need to pay due regard to each of the 4 health and wellbeing strategies across South Yorkshire in developing its plan. Again, my understanding of the integrated care partnership is that that will have representation from all 4 health and wellbeing boards, and that will also have to pay due regard to health and wellbeing strategy in developing the plans that it kind of mandates the integrated care board to plan for. As I've mentioned already, the integrated care system will be moving into that statutory role. There's a big emphasis on working as one system across SYB, across South Yorkshire rather. So it will be one organisation. There will be one workforce working within the ICS, but there will be 4 very strong place-based teams operating in that. And the reason for this really is to sort of try to deliver the fundamental purpose of ICSs, which is outlined in the legislation or proposed legislation, but also in the 5-year plan South Yorkshire and Bassetlaw ICS strategy. So 4 kind of headline things that we are looking for is an overall improvement in health, in population health and outcome there, to tackle unequal outcomes and unequal access within places and between places. There will be an emphasis on enhancing productivity and value for money. There's an awful lot of repetition that goes on in the NHS, so some of reduced repetition not only helps financially, but it does help improve patient experience. And the final part of the purpose of ICS is to help the NHS to support broader social and economic development in each of those 4 places. There's a very important section in there on patients and users of service, but also carers. And so as we progress, there needs to be an embedded culture of designing services in conjunction with local population and with local service users. And I think that probably brings a degree of democracy to decision-making around health. So not political democracy, but the population democracy in their involvement there. As things stand in Sheffield at the moment, we've got quite a strong culture of working directly with members of the public and involving them in co-design or co-production of our services. And that's something that we certainly would want to be embedding into joint commissioning arrangements in the future. I'll just move on through my notes here. I think the second really important kind of emphasis here is, as the ICS becomes a new thing, it isn't a case of CCGs being dissolved and something completely new being set up. So the real emphasis there on the transition of functions from one to the other. And those transition of, well, we talk about transition of functions. We also include in that the transition of people into that one workforce, the transition of assets, which include our estate and any other financial assets we have. And it also includes the transition of contracts and legal agreements. So we would anticipate that the CCG's Section 75 delegation that allows us to pool that 428 million with a local authority will continue and will be transferred into the integrated care system, unless there is a desire for Sheffield City Council not to continue with that arrangement. So we are hoping that over the next couple of months, following discussions with local authority colleagues through the Joint Commissioning Committee, we will be able to get to a point where we're able to sign up to a draft delegation agreement to be able to exercise some of those functions through our Joint Committee here in Sheffield. I'm going to stop there, and if there's anything I may have missed from that paper or anything anybody else wants to pick up, please do ask.
Thank you, Terry. Before I ask Alexis whether or not she wants to add anything or make any comments on that and subsequently bring in members, I should mention that Emily has been in contact with the Centre for Governance and Scrutiny. As Terry said, that the legislation, as people may or may not be aware, has passed the it's gone through the second reading and it is now at committee stage. My understanding is the first committee, parliamentary committee will be on the 7th. And then on the 9th, and the Centre for Governance and Scrutiny has. I'll hand over to Emily. They've been in touch with Emily about presenting evidence to the committee stage on the session on the 9th, and they've very much welcome comments from today's scrutiny meeting that they can feed into that. Don't you elaborate, Emily?
Sure. It's probably just worth flagging that one of the things the bill does is quite quiet on the future of scrutiny in the system, but one of the things that it does do is gives the Secretary of State the power to intervene in health service reconfigurations at any point, I think, around, which is likely to lead to local authority scrutiny losing that power of referral to the Secretary of State. So as last time we were looking at the changes to speech and language therapy and whether you considered them to be a substantial variation and therefore kind of formally consult on those. With that change, it is expected that you wouldn't then have the power to refer concerns to the Secretary of State if you had them. We're expecting more detail on that to be in the regulations and the guidance, but the Centre for Governance and Scrutiny is giving evidence to the committee on the 9th and is very interested in anything you have to say, particularly around local accountability and that sort of thing. Was that clear?
People follow that. Anyway, we'll come back when we bring in members. Alexis, I'll hand over to you. Would you like to come in?
Firstly, thank you very much for the opportunity to speak today and come along to the Scrutiny Committee today. My name is Alexis Chappell, I'm the Director of Adult Health and Social Care. So Terry's already set out the arrangements for the ICS arrangements and the development alongside the bill. And equally, Councillor Steve Ayres has also set out the arrangements for the Health and Social Care Bill going through Parliament just now. And one of the key things is expected to go to the House on the 2nd of November 2021 with expected assent on the 1st of April. It's helpful to note that there's been a number of guidances already been published by NHS England in anticipation of the bill, but also to support transition and implementation of the bill from next year. So it's helpful to note that at this stage within the committee. And if it's helpful, we'll make sure that links are given to this committee as well for going forward. Within the bill, there's also a note within that in terms of adult social care is the proposed development of an inspection framework for adult social care as well, which is also contained within the Health and Social Care Bill. And that's something which we are currently preparing for. And we'll bring back, further information in due course as more information emerges as the bill goes through the Parliament. So it's helpful for committee members to know that that's a future implication for the council. And alongside that, just to build upon Dr. Terry Hudson's point, is the other key point for us is the ongoing that the Health and Wellbeing Board has not changed. And that remains as the key strategic body for Sheffield in terms of health and well-being. And alongside that, our focus remains on building and securing a future relationship with the NHS and integrating care as set out within the one-year plan that was recently published by Sheffield City Council as well. So at that point, I'll just stop, and that's the key points for myself, and open for questions.
Thank you, Alexis. I think at this point, I mentioned earlier that Lucy Edwards from Local Health Watch sent apologies, but she did send a couple of comments and questions, which I've agreed I'll sort of read out. Very simply, well, very brief. Where does a member of the public go if they've got a concern about care? Where can they raise it? Where can it be unpicked? And the other question she's asked is, how can Team Sheffield influence and shape the way the ICS engages and involves citizens in decision making? So those a couple of questions that Lucy has sent in on behalf of Health Watch in Sheffield. Right. So think that I'll open it up now to members. So if you can indicate, and I'll try and write your name down. So,
Thank you, Chair. Thank you, Terry, Alexis, for the summary of the report that you provided. I've got a couple of questions, maybe clarification in some areas. So the first one follows on from the questions that the lady from Health Watch has requested. So in terms of local people, I know you mentioned, Terry, that we've been quite good at getting communities to be involved in co-design. Some of the things that I found, or experiences that I found working in communities, is that very often seldom heard communities we struggle to reach, and very often from minority groups we struggle to engage as well. So in looking at place-based teams, how are we going to make sure that those communities are reached in making sure the service design and not just working with the larger institutions that are perhaps easier to engage with? So that's the first one. Second one, you mentioned we're working in a larger footprint. So working in a larger sort of scale alongside the additional barriers of, sorry, not barriers, but pressures of increased level of need in adult social care. Is this going to affect funding, and does the level of funding that we have, is it still the same? Because of the larger footprint, does that mean there's less money to be spent in Sheffield? So just in terms of money and funding for Sheffield, what impact does a larger footprint have balanced against the pressures, the increased level of pressures that we've got in meeting the needs of adult social care? That's the second. Third, there's been quite a lot of sort of concerns nationally about whether integrated care systems will lead to increased privatisation. Sheffield, we've got an ethical procurement strategy which looks at how we ensure that our funding goes to local organisations and primarily works with the maintained and VCF sector. Are there any core values that Sheffield will have going forward to make sure that that ethical procurement policy is taken in place and we're not sort of set on stream to more privatisation? That's the third. And then the final question is just in relation to how needs are assessed. Previously, we used to have the joint strategic needs assessment. How will the integrated care system work in terms of assessing need? And how will communities, organisations be able to influence the sort of the various ways in which we assess needs? So because that ultimately affects what delivery happens going forward. Thank you. Sorry, they're quite big questions.
I'm glad I brought a pen and paper with me. That's quite helpful. Do you want me to try and answer those for you?
Yes, if you can.
Yeah.
Thank you.
Okay. So the first question was around co-design and ensuring that seldom heard groups were perhaps better engaged with and better involved. And I think at multiple different layers, so within our Health and Wellbeing Board, within our Health and Care Partnership, and also as commissioners, we recognise that we probably need to do better than we have done traditionally. And certainly through the work of the Joint Committee and also the work of the CCG, there's been an evolution over several years and a lot more challenge internally about how we do that well. Whilst things are not perfect, and I think we recognise they're not perfect, I think some of the engagement work that was done jointly between the NHS and the local authority during COVID, particularly around reaching groups that wouldn't have normally been vaccinated, whether vaccine hesitancy, and ensuring that the approach we took to that wasn't a paternalistic organisation knows best approach, but actually approach of working with local communities to understand the barriers, but understanding within those communities they often had the solution, and making sure that they were appropriately resourced to do that, and outreaching into those. So there was something there about trusting local people to know what was best for their local communities. And I think as we begin to look through many of the different ambitions that are set out in the Joint Commissioning strategy, there is ample scope to do that. And I'll defer to Alexis in a moment to talk through some of the detail of what that looks like. but there's certainly a commitment to continue to do that. In terms of the larger scale, there will always be increased pressures, and I think that there are sometimes benefits of working at scale. There are some things that we have failed to do in Sheffield because perhaps don't have the critical mass there. And in terms of sort of particularly picking up on the funding point there, that's not clear at the moment. There isn't anything set out, so I'm not able to kind of answer or perhaps second guess what will come through from the Department of Health. But the indications from NHS England are at the moment that the system envelope, so the allocation of funding to our 4 CCGs will remain the same within the context of the integrated care system. And this has largely been happening already over the last 18 months. The NHS refers to funding through systems and system by default. And we've continued to allocate based on historical spend and historical needs assessment. So it gets to the point there about, well, will we have the same level of funding in Sheffield? And we have to recognise that we'll have delegation for spending things on behalf of the ICS in Sheffield, but in none of those arrangements will it be funding directly coming to Sheffield. It will always be to the integrated care system. The second bit is if we look at the CCG budget as it is at the moment, it comes in at around 1.1 billion to spend on health services. We currently have our 428 million delegated into our joint committee with, as I've indicated earlier, an ambition to bring more of that resource for local decision making. But if that was all that was delegated to Sheffield, we shouldn't look at it as a loss of 500 million to something else, because that funding will still be used on Sheffield people. It will still be used for the benefit of health and care in Sheffield. It's just that the decision making and the planning of that will be done in a different context. So it's really helpful, and it's quite hard conceptually, but it's really helpful to think about system and place being one and the same thing. But it's actually quite difficult because people kind of almost talk to system as though it's something different that we need to compete with and compete for resource from, but actually it's one and the same thing. And very much the transition process that we are trying to work through at the moment is that we continue to have NHS people, and Team Sheffield was used earlier, but that Team Sheffield of the ICS working in place and that system simultaneously, so that there is a connect between the two. And what we don't end up with is sort of a historical strategic health body that's sat somewhere else behind closed doors, and not really connected to the decisions that are making there on the ground. And that probably brings onto the next point around privatisation. So again, I'm not going to second guess the government's plans. I think that would probably be a miss of me. But we have to recognise there's already a degree of private provision of services, but it remains publicly funded, so that we wouldn't anticipate that we'll start charging people to see their GP, or charging for A&E, for instance. But as with social care, there are a number of private providers that provide those services on behalf of the NHS. And in Sheffield in particular, there are private providers that provide a number of outpatient services. And some of those are contracted directly from commissioners. Others of them are actually subcontracted from our NHS provider colleagues. So it's a mixed model there. However, in terms of that ethical strategy that you've picked up on there, I don't think it would be incongruent to continue to follow that through the joint commissioning arrangements. I think if we go back to one of the purposes of an ICS is to help with social and economic development in South Yorkshire, but also in Sheffield. There's a really strong ethical argument there that if you're going to be looking at that type of development, actually you do want to fund local organisations, you want to fund local community anchors, voluntary organisations, community enterprise, to begin to develop different models of care. And I'll probably again defer to Alexis on this one, but there's been an awful lot of detailed discussion through the joint committee space about how we help voluntary and community organisations become more sustainable through our funding models, and how we support them. and actually how do we recognise the increased value that they bring, throwing more money at health services doesn't bring us. So actually I do think that there'll probably be some congruency, but I suspect there will be some tensions as well, and there will be things that will have to be worked out in time. Final question around the JSNA, so the Joint Strategic Needs Assessment. My reading of the bill as it's gone through, and my reading of the NHS England guidance, is that the JSNA remains. It's an important component that's tied to the Health and Wellbeing Board, and it will be the partnership component of the ICS that will have to pay due regard to our Joint Strategic Needs Assessment here in Sheffield. So the mechanisms that we have here in terms of involving local voice, local communities and contributing to that will continue. I'm not sure that that arrangement is the same across all other local authorities in South Yorkshire. So there's an opportunity there for us to teach the others how to, perhaps they might want to do that better. Again, that's an opinion for you guys to have there. But the ICS must pay due regard to that JSNA in terms of developing its own strategy.
Okay, up to some. Bernard.
Thank you very much for your presentation. Most clear. I note that we're being asked to give support for the direction of travel for the integrated care system, and give support for the direction in Sheffield. Several questions. First one is, I'm always surprised, I don't know why I am, but I'm always surprised that public health isn't in the mix, that it remains a nationally directed organisation, which is enormously disappointing, because actually, local people do know best how to deliver services integrated within, within our local communities, in our streets, in our actual places, which I note is also a phrase that you have still got in there. So, has the Director of Public Health in Sheffield expressed a view on this direction of travel? Have they expressed a need to be much more involved in delivery? Secondly, I'm aware that the National Health Service has got a very, very challenging target to meet the climate challenge. They themselves say that it's going to be very, very difficult. Is this paper, is this direction of travel actually going to help that? My third question is related to that. Are you aware, and how is this impacting your planning, that Sheffield City Council has adopted and is committed to reduce carbon emissions in the city, and by implication, how much the embodied energy that it's consumed, that it consumes from things that are bought in? That this council has set a goal of zero carbon by 2030. Has that been incorporated in the thinking behind this? As for delivering with local communities, Sheffield is in the process of implementing what we call a local area committees. The city is divided into 7 areas, and in order to deliver greater local democracy, what role will the local area committees have in shaping how the health of their local community is improved? Because that is our commitment for the communities to be safer and more healthy places to live in. where will the input within our local area committees reside? I'm chair of the city centre local area committee, and I would be fascinated to know how that is going to be impacted. For example, we at the moment have absolutely zero control of how buses are run in the city. We've got levels of air pollution in the city that are horrendous, yet we have no control over that. And just remind you that every year we have 500 excess deaths, premature deaths as a result of air pollution. And if we had control of our public transport in the city and could actually have some leverage there, we could make a considerable impact on public health in the city. Thank you.
So, thank you, Bernard. I'm probably going to kind of dodge the question about public transport because that's a little out of my remit, if I may. But I will try and address some of the other questions that you've made. And two of them in particular, I'm going to sound a little bit sad here, but I'm quite excited by the question because I think you put forward some really good points and there's an awful lot of potential. And there is no blueprint, and I think I probably haven't emphasised this clearly enough in presenting the paper, is that whilst there is a legislative framework for ICSs, there is no blueprint as to how an ICS should be designed, and there is no blueprint as to how that place partnership should be designed. So in many respects, it does give us some quite exciting opportunities in Sheffield in particular. So just wanted to pick up on the first one around the climate and the carbon target that the NHS has set itself. So the NHS Green Plan, that has been discussed at CCG level. It's also been discussed in some of the provider organisations, and indeed is being discussed at the ICS. And we need to just recognise that the ICS isn't quite in shadow form yet. It is just a partnership. But within that, we have recognised, I believe it's around 5% of all car journeys in the UK every day are made by people travelling to and from NHS appointments. So there is an opportunity for us to leverage new technologies where possible. I probably don't want to be steering too much into the debate about telephone and virtual consultations with your GP at the moment. That's a bit of a hot topic. But actually there's an awful lot of opportunity there. You know, why does somebody drive all the way to the Northern General from their house at Low Edges to be told by a consultant their x-ray is normal and then drive all the way back home? So there are a number of opportunities that we should be looking at as a system. Now, those things probably aren't going to be legislated for, but there's certainly an opportunity for local authority colleagues and for local communities to input and apply pressure such that those decisions are something that are taken seriously. The second bit that you mentioned was around the local area committee structures, and that's a topic that excites me as a GP quite a lot. So within the current structure of Sheffield CCG, we support general practice and networks of practices coming together called primary care networks, or PCNs. We support those through 4 locality groups. Now, the locality groups at present have 2 roles. One of them is to bring frontline clinical voice to decision making by the Commissioner, and in reverse. So for the Commissioner to support frontline services. Now, one of the core purposes of primary care networks is to do what we call population health management. So that's to improve the health of their local population and to reduce health inequalities. Now, one of the things that we have long struggled with is the real link between people's health outcomes, the environment that they live in, and the wider social determinants of health. So again, this is not policy, this is a reflection that there is an opportunity for those PCNs and those localities to potentially align to the local area committee structures, so that you can begin to link up some of the discussions around people's health and well-being and the wider determinants of health that you may be able to begin to address through the local area committees, be that green spaces, be that exercise, be that transport, education, whatever happens to kind of be discussed there. And as I said, there is no blueprint for how places should work. Now, as we have at the moment, we've got a joint committee which currently involves 4 elected members from Sheffield City Council and 3 non-executive members of the governing body of Sheffield CCG. So that includes the chair, another GP, one of our lay members and an executive officer. We have to have somebody who can sign the budget, hence why that's there. But as we move into that joint committee no longer being with the CCG but with the integrated care system, it does provide quite an exciting opportunity in terms of what will the terms of reference for that committee look like, who will be involved in that decision making, and actually I would probably reflect the balance of power in terms of the makeup of that committee probably resides with Sheffield City Council as much as it resides with the ICS. So you may look at your local area committees and decide that you would like representation into the joint committee directly from local area committees. For example, you might say that you want to have some frontline clinical representation from a locality. That is very much up for discussion, and that's very much up for local determination and not for the ICS to determine how that will work. So I've not quite answered the question on where will the input be and where will that reside, but I think the reflection back on there is that's for determination, and that's for determination here in Sheffield. Alexis, do you want to pick up?
Exactly.
Let's let my throat recover from all the talking.
So just want to firstly say thank you very much for the questions. I think it's really exciting questions in terms of the opportunities and going ahead. And as Dr. Hudson said, is that there is no blueprint for place-based arrangements and the ICSs, so it's really ours to shape in Sheffield, and that's the way I've seen this and kind of coming into post. And we have a real opportunity to really go and harness that and take the challenges that are put forward and say, how do we improve lives and outcomes for people of Sheffield and all communities across Sheffield. Certainly one of my key priorities in coming to post was to take forward a focus on co-design and co-production in all developments that we undertake, and that includes any joint developments with our health colleagues, and ensuring that principle is embedded in everything that we do. So to that end, a couple of key things are already underway. In terms of the development of the adult health and social care strategy, we have a group together of colleagues from right across the sector to co-develop and co-design an adult social care strategy for the future that's fit for the future. And for me, I want it to be ambitious and include absolutely how we support and contribute to climate change, how we support and contribute to reducing carbon emissions, because we're a big sector in social care and in health, and we have a big impact. So it's really important that we take the challenge and we think about that as part of what we do, but we also very much focus on communities and how we very much involve and work with local area committees as they shape and develop, across Sheffield. And then secondly, in terms of the Joint Commission Committee, we have a wonderful opportunity to go and build upon that arrangement which exists already in Sheffield as the ICS develops. And one of the key things that we are developing just now is how we shape that for the future. And so for me, the question around how we contribute to climate change, how we co-design with our communities, how we reduce carbon emissions, and how we very much fit with local area committees is what we're looking at just now as part of the developments and the governance of that and going forward. So it's I think it's a great question, and if it's certainly from my point of view, I think it'd be really great to have a discussion out with us and how we could absolutely work with you to go in and give you the assurances that both in terms of the adult social care strategy and the joint commissioning developments that we do that and taken forward.
Yeah, can I just add to what's been said? You didn't touch on the public health aspect of this I just feel that that's such an important key to, you know, the crisis, the pandemic crisis that we remain in. And I'm appalled that the foot is being taken off the accelerator on that. And I think the public health should have been very much key to public strategy, government strategy throughout this pandemic. And then it's looking forward as chair of the local area committee in the city centre, with other services within the city, the agreement is that we've got particular people, named officers, individuals from other parts of from services provided within the city and beyond, people we can actually speak to, ask for them to come to our meetings. I'd very much like somebody from integrated healthcare to come, you know, to be on tap, as it were, to explain, look, these services do not complement each other. They're actually pushing in completely different directions. I concur again with, you know, yesterday I had to go, I live in Walkley, I had to go for an appointment to see a podiatrist at Meadow Head. There was no way that I could guarantee I could get there by public transport. The bus is, the buses are so unreliable. I don't want to use the car because I am committed to cut my emissions. I had to cycle there. You know, it's outrageous. It took me nearly an hour to get there. I'm reasonably fit and healthy, but I wouldn't expect anybody to do that. So at the moment, we've got a system that is unfit for purpose. Thank you.
To pick up on the public health point. So I'm inclined to agree with you. And again, I can only give my reflection here from the CCG, and indeed from some of our other partners in the existing integrated care system, about the lack of involvement of public health. However, as we've pointed out, the blueprint is not there, and therefore we can involve public health to whatever extent we would like public health to be involved. So I think it's just worth picking out a few points there, that public health directors can be involved in the integrated care partnership to steer that strategy. Our public health director here in Sheffield is very much a core member of our health and wellbeing board, and again is kind of helping steer high-level strategy. And finally, our health and wellbeing strategy is actually written by our public health director. And finally, the JSNA is something that sits underneath there. Currently, our Director of Public Health is a non-voting member in attendance at the CCG board, so they're currently involved in those commissioning arrangements. And there is nothing that would stop Director of Public Health actually being involved in the joint committee moving forward. So again, that's something that can be negotiated into that terms of reference. I think importantly, if we go back historically to when those joint commissioning arrangements first came about, in fact, they were driven by our Director of Public Health. So I recognise at the moment Greg's probably the busiest man on earth in terms of juggling, the response to the pandemic on top of the day job. And unfortunately, he's perhaps been slightly less engaged in some of this, which might actually just be a bit of a distraction for him at the moment. But very much we keep involved with Greg and engaged with Greg through Health and Wellbeing Board and through the Joint Committee, plus through Governing Body. And I think, we probably all want to see our DPH being involved in that moving forwards. But I think the important bit that you're kind of getting at there, Bernard, is how do we bring that DPH voice to a broader geographical footprint. So again, having sat in some of the ICS meetings, the public health directors come as a group from all of our places, and they are setting out a lot of information around how to tackle health inequalities better, how to manage kind of population health in an improved way. So there are mechanisms that are already there. We're already doing those things, but they're not enshrined in law, and there shouldn't be unless the law prohibits the DPH from being involved, I don't think anybody would be closing the door in their face. I think we'd really want them involved. Okay.
Francine.
Thank you. Thanks for your presentation. I'd just like to say that I do share the concerns that have been raised by a number of others about the increasing opportunities that ICSs will provide for private companies, particularly in terms of scale and data opportunities. I know that a number of approved companies have been put forward to support the setup and management of ICSs, which include companies like American health insurance firms. And I'm aware that in Bath they have a private provider on their board, on their ICS board. You've spoken about the sort of flexibility that we will have locally to sort of shape the kind of ICS that we want. But I'm also interested, in terms of what cost-cutting pressures and things like that are likely to be pushed down on ICSs. How reasonable is it to expect the sort of local, democratic, accountable partners that there are to be able to kind of safeguard the city against those forces, or is it almost inevitable that we will end up with private companies on the ICS board, or with private companies managing the data of the people who use the services? My other concern is about the impact on staff and the potential impact of pressure to outsource private companies on the nationally agreed pay terms and conditions of staff. Also, the other knock-on effect of that is potential degradation of services as well. If things are put out to private companies, it's possible that jobs will be advertised to people with less qualifications, and that could have a knock-on effect on patient care. Finally, these sort of factors coupled with sort of decrease in local accountability and transparency are deeply, deeply concerning. Thank you.
Thank you very much for your question. Really, really good questions, and also very thought-provoking questions about the future direction. And I'll maybe answer your last question first, and then go to the question about private providers. In terms of impact on staff, there has been two key aspects to this, and I'll bring in Terry about the impact on NHS staff separately in terms of the ICS developments. In terms of the social care staff, is one of the key commitments I made within the one-year plan was to develop a long-term workforce plan, which includes setting out how we will achieve the foundation living wage for our wider social care sector workforce. And as the statutory DAS for the council, I have a responsibility not just to my own staff in the council, but also to the wider social care sector. And so for me, it's been absolutely a priority to look at how we set out and achieve the foundation living wage. And that's why it's in the one-year plan, and that to me is securing that commitment as we go forward. And that's something I'm working on currently just now, trying to figure out how we do that, because it's an absolute priority, and it's absolutely about empowering and valuing our social care workforce from now and into the future. And then the second aspect in terms of in relation to private providers and democratic accountability. One of the key opportunities that I talked about earlier on was there is no blueprint, but we've also got good arrangements already in place in terms of the Joint Commissioning Committee. And one of the opportunities that we have through that, because it's already has elected member representation on the Joint Commissioning Committee, is that's where we secure that democratic accountability. And one of the key pieces of work that we've committed to undertaking is how do we secure our future relationship with the ICS, building upon that Joint Commissioning Committee where we have local members and a delegated budget and delegated accountability to go and take that forward, so that we're absolutely ensuring at a local level members could absolutely be having a view on our arrangements at a local level. And that's one of the key pieces of work that we are currently working on just now. And I'll maybe hand over to Terry if you want to add to that.
Yeah, so I'm just jotting some notes here because I think a lot of the questions you've put there, they're thought-provoking, but there's not a lot of overlap between those different questions. So I'll try and unpick it a bit, but do interrupt me and try and get me to bring it back together if it's not as clear as you hope. So I'm going to pick up on the NHS staff impact to begin with. So under the plans for integrated care systems, there should be no impact at all on frontline health and care staff. So those people delivering care in hospitals and in GP services are not affected by the proposed legislation or by the ICS itself. So we shouldn't see any changes to that. There are some staff who will be affected who don't sit in direct provision of services. Those staff are broadly those employed by CCGs, and then also some staff from NHS England, and then some staff from bodies called commissioning support units. We don't have one here in South Yorkshire. And there is currently an employment guarantee for those people from what is essentially all staff, with the exception of anybody who works at board level or reports in directly to a chief executive. So essentially, for our 300 and I think it's 63, the number changed recently, CCG staff, they will transfer as a lift and shift arrangement into the new integrated care organisation. And in particular, it will be into the integrated care board, the NHS body proper. Those people at board level, I don't know the answer to that. I don't think anybody does at the moment. There's an emphasis on executive directors being found suitable alternative employment for the GP members and the lay members. I think it amounts to 3 sentences in a 60-page document that just doesn't really say a lot other than you don't exist when you're dissolved. So on the whole, actually, the majority of people delivering the planning, the monitoring, all of those important commissioning functions will be unaffected by that change in terms of their terms and conditions. They'll be under a GP arrangement. So that one's quite important there. In terms of private companies being involved, currently the South Yorkshire integrated care system doesn't have any private organisation represented beyond the involvement of certain community organisations that might be constituted as a community interest company or a limited organisation. So that would be the extent to which private organisations are involved in the integrated care system as is. I don't think there's any plan, as far as I've seen, to have a private provider on the board of the organisation. And I think politically that would probably be quite sour to the 4 local authorities involved. So I think the integrated care system leaders are perhaps sensitive to some of those politics as well. So and I think, you know, if they did something like that, I think many of our hospital chief executives and GPs would be up in arms as well. So I don't think there's a big risk there. The extent to which private organisations are involved in the ICS is there's a company that works exclusively with the NHS, providing some consultancy and project management services. You know, we use those on an ad hoc basis, and there's a long-standing relationship there, but that doesn't amount to privatisation of the health service itself. It's just buying in some resource and capacity there. The final bit about scale, I think is quite an interesting question. As we conceptualise scale as scaling up, i.e. expanding and getting bigger, and quite rightly, you know, that brings up questions about, well, where do you get the resource from? How do you do that? But actually, in the context when we talk about scale within the ICS, we're not talking about scaling up. We're talking about working in a collaborative way with other organisations. So in particular, the suite of documents that NHS England have released talk about provider collaboratives. And that's where they talk about scale. So at the moment in Sheffield, we've got one acute adult hospital. Now, it struggles with some things. It struggles to meet its waiting times on certain things. It struggles to recruit radiologists, pathologists to be able to process and deliver results down. We've got similar problems in the other acute hospital providers across South Yorkshire. So when the documents talk about scale, they talk about collaboration between acute hospitals. They talk about collaboration between mental health providers across South Yorkshire. So they term this the horizontal collaboratives. So working at scale is saying, well, there are many services that we could share so that you get an economy of scale by working together, as opposed to how do you scale up into the private sector. And there are examples of that where it's worked quite well already. So I'll kind of pull out the stroke pathways. So that hasn't materially affected the ability to deliver any stroke service in Sheffield. But what it does mean is that if you present with a stroke at Rotherham Hospital, where there isn't a consultant 24 hours a day, you can have your acute stroke treated here in Sheffield. And once that acute episode's over, usually within about 24 to 48 hours, you can move back to Rotherham for the rest of your recovery. So very much that at-scale provision is about building the networks between the acute hospitals and the mental health providers so that you can begin to, hate the term, but kind of level out the outcome across South Yorkshire, because I think that will be a dilemma that any new ICS leader is going to face. Why should somebody in Barnsley or Doncaster die of their stroke, yet if you live in Sheffield you don't? And that's a really important question, and quite often I'm met with resistance, but it's okay for people in Sheffield. We've also got to be cognizant it's not acceptable for anybody else anywhere else. So the scale in particular isn't about buying in new capacity. It's about making sure that we use the capacity we've got in South Yorkshire to the best of the ability we've got, but making sure it isn't to the detriment of anybody that lives here. So children's surgery, children's anaesthesia, there are various other projects that have been underway for a number of years that have been quite successful in their outcomes. So, does that answer the question? Thanks.
Sue.
Thank you, Chair. And thank you, Terry and Alexis, for the very detailed presentation. And I have to say, the very detailed answers that you've given to the questions that have been put to you so far, because my questions, when I indicated, were around who were going to be on the boards and how that was going to fit with this authority and, importantly, with the local area committees. And I think that that's been answered very, very well, and I am hopeful and optimistic, and we'll watch that with great care. My second question was actually something that Francine, Councillor Johnston, has put to you, and again, you've answered that, and I feel somewhat reassured. I suppose more generally, I am concerned about how it's about money and budgets, and how that money is, how the precise amounts of the budget within the budget are going to be allocated across the area. But because when you're working sort of across South Yorkshire and you've got a budget and there's different areas competing for that, I think that's going to be very difficult. But I think in the main, all my questions that I was going to put have been answered. So thank you very much for all of that.
So the budget question is a really interesting one. Again, the answer is we don't know what the allocation formula would look like within a system. But what we had, and this was given to all clinical commissioning groups through their existing ICSs back in 2019. This one sort of spun off, or maybe in 2020 in fact. It spun off shortly before the pandemic. It was a difficulty that the NHS every year gets its budget allocation. It usually gets informed of the budget allocation about 3 days before the beginning of the financial year. It makes it really difficult to plan. So often we plan in the dark and then hope what we've planned for is the reality. Recognising that, the Department of Health and NHS England made a decision to publish 5-year funding packages so that systems could plan in advance. So we're not anticipating that that 5-year forecast should change, but your point that's quite important there, Sue, is how is that allocated within an ICS? And I think it sort of becomes quite interesting. Are places competing, or are all 4 places in the ICS one and the same thing? And that will become a really interesting dilemma. But it won't be on my head to make the decision because I won't be here to do it. But yeah, I think there is an important bit there. I think rather than reflecting on how do places compete for the resource, I think, yes, you would want to make sure that through your joint committees you've got adequate resource to do the things that you can do best within a local place. But rather than having assurance about is the money flowing into Sheffield, you want assurance, is the ICS delivering all of those things across those 4 places? So less concerned about the money, but more concerned about what the outcome is against that budget that is being retained for the whole system working. So that might just change the dynamic of things a little bit, but I would anticipate that might be a direction that local authorities and overview and scrutiny committees might be wanting to consider. And I think there's probably a really important role there for the joint oversight and scrutiny committee between the 4 South Yorkshire CCGs to think about how it might put that challenge in as well. But I'm not au fait on the politics and how all of that works. I do apologise. Just a thought.
Okay, Sue. And last one I've got on the list.
Thank you. Thanks for the presentation of the report, which was I found quite reassuring in some ways, and what you've said since quite reassuring in some ways. I've got a few slightly disparate questions, and some of it has been covered by other members. Just very quickly back to the workforce question. I caught you said, Terry, that it will be one single workforce across the ICS, and I just wondered, are we talking about clinical or non-clinical staff or both in that context of the one single workforce? And is there therefore the potential for redeployment across the ICS area that could obviously affect the workforce in obvious ways? And what kind of protections would there be against that becoming a thing? I also wanted to ask about, just to go back to the private bodies, the private providers sitting on the board, which you've more or less answered according to the question I would have asked. But is it, just to sort of really drill down on that, is it within the gift of the ICS? And I'm sort of asking, since we've said there's no blueprint and, this is a thing that's being designed locally, therefore can it be written down that there should not be private providers ever sitting on that board? Is that in our gift to have that written down? Then Terry, you just asked the question, why should someone in Barnsley die of their stroke when someone in Sheffield doesn't? We had a closure, didn't we? Hyperacute stroke unit in Barnsley. So your question sort of hangs in the air a bit following that closure. How worried should we be as we move to statutory ICS that other closures like that could happen because things are organised on the footprint level? That closure seemed far too easy to me, despite some public resistance and the threat of a lawsuit from a campaign body. It still went through very, very easily. So how concerned should we be that bringing the ICS in at a statutory level will make that kind of thing much easier should future rounds of reconfigurations become necessary according to our government? And finally, someone's got to ask, there's no blueprint, so what flexibility do we have regarding the ongoing role of scrutiny committees? Are we in a position to more or less re-establish scrutiny committees at place and ICS level, more or less as they are now, and maintaining the function largely as it operates now to scrutinise both place and footprint? And what opportunities would there be for existing scrutiny committees for members to discuss their future role with those who are designing the ICS. Who is designing the ICS? Thanks.
I'll have a go at picking some of those up. In terms of the exact detail of how you form a scrutiny committee and so on, I'm going to defer back to you to discuss that. So the first bit around the workforce, in reference to that, it's the CCGs, so the commissioning bodies, so people who plan, purchase, monitor healthcare services will form that one workforce. What we're not talking about is all of the hospitals joining together and creating a new clinical workforce. So it's broadly speaking the non-clinical workforce. We do have some clinical workforce within our CCGs, and they tend to pertain to people that look after continuing healthcare. So the people that make the assessments for various care packages, and a very, very small degree of direct patient care. Now, under the arrangements set out by NHS England, that is a lift and shift. The staff that are in Sheffield will be changing their payslip, but will continue to interface directly with Sheffield. And of course, any change to their terms and conditions or their work base or whatever that needs to be needs to go through a due employment process, consultation with unions and so on. So there should be some protections there. In terms of the remainder of the workforce, it's quite an interesting question. So if we've got a particularly special talent in one of our 4 places and we want to share that, that becomes a different question, doesn't it? So it wouldn't necessarily be about redeploying people to different areas, but it's about making sure that we can make the best of the resources, the human resources, that human capital that we've got. So there may be some little bits of redesign over time, and you know, they'll probably pertain to some of what we do already. And many of our staff in the CCG are aligned to system working. So in terms of business intelligence, in terms of data, in terms of contracting for certain things, Sheffield CCG already does that on behalf of the whole ICS. So I would anticipate there will be teams within the ICS, or the new ICS as it is, that will be joining some of those functions together. But picking up on Bernard's point earlier about, you know, green impact, I don't know why on earth we would be asking people from Doncaster to drive into a meeting in Sheffield when we can switch a computer on and make that happen. I think we're really cognizant of that, and that's really, really important that we do that. So that's the one workforce question is around CCG staff only, and not about redeploying, you know, a hospital doctor to, you know, Mexborough Hospital or something along those lines. In terms of the private provider question, it potentially is within the gift of the ICS, and there are some fellow councillors that you've got here that are in direct discussions with the ICS. I think it's probably something you want to discuss internally. The interesting part is the constitution of the ICS will be written by the outgoing CCGs. An organisation in the NHS can't constitute itself. So we will be writing that constitution, and I think there's a fairly strong feeling across all 4 of our CCGs that you know, we would want a strong view on that. So, you know, certainly use your political prowess to lobby the CCG chairs and executive accountable officers across South Yorkshire to consider including that. Now, I've seen there's a model constitution which is kind of half populated with a few bits and pieces that NHS England have produced. I haven't seen anything in there about exclusion of private providers, but it may be something that you know, we want to do. I think we'll probably get into difficulties if you try to exclude contracting with private providers, because that leaves us in a really difficult position that we do have private providers providing social care, and we also have private providers providing some healthcare elements. So, but the point around a private provider on a board, I think might be a significant conflict of interest. And personally, and again, this is my personal opinion and perhaps not the opinion of the NHS, I wouldn't want to see that either. So I'm sort of in a position where I might be able to influence that one, but we can pick that discussion out. And then Barnsley, so bringing back to, you know, kind of what assurance will there be? So Barnsley never had a hyper-acute stroke unit per se. Barnsley had a stroke unit, so before hyper-acute stroke units became a thing, each of our hospitals had its own stroke service. And the reason Barnsley Stroke Service was closed was because they couldn't recruit a consultant who was specialised in stroke. They had a locum consultant that they could have a few days a week. And actually what was happening is that ambulances were going to Barnsley Hospital with stroke patients and there not being a service there for them. And actually that puts people in danger and it puts them in harm's way. And I believe it was NHS England made a decision just to pull that out of there. The reconfiguration element of stroke services was the 5 CCGs coming together across South Yorkshire and Bassetlaw, working out where there were stable and concentrated specialist services, and arranging for patients. If you have a stroke and you drop down in Barnsley with a stroke, now the paramedic just drives you straight to Sheffield, so that you get treated quickly. You get your thrombolysis hopefully within an hour of the event taking place. Thereafter, once you've had that hyperacute phase, that early 24-hour phase treated, you're then transferred back into your hospital. So that wasn't a decision that was made by an ICS, actually. It predates the ICS. So we wouldn't anticipate that ICS is going to be looking at closing things left, right and centre. But there are some very, very real and significant workforce threats to South Yorkshire at the moment around certain clinical services. And there may be, I'm not going to use the word consolidation, but actually some services are at the point of failing. So there's something about ensuring that there's an adequate network of services such that you are able to ensure that all people in South Yorkshire have got equal access to the appropriate treatment. So it's a difficult one, but I wouldn't anticipate that ICS is going to come along and say, you've got a really good hand surgery centre here in Sheffield, they've got one at Doncaster, let's shut one and move everything else. It wouldn't make sense for them to do that. And it would go against one of the 4 principles of ICSs, which is about reducing health inequality. And you don't reduce health inequality by only having services in one area. You make sure that there is equal access. And some of that may be actually using, stopping people travelling. Go back to the green point, why would you have 30 patients travel to Sheffield for an outpatient clinic when you can send one consultant to Rotherham Hospital to do the clinic there? So in terms of some of that networking, it isn't about redeploying them. The ICS can't do that, but the hospitals working at scale across their provider collaboratives might be able to move resource temporarily where it is needed most. And we do that already. So the Children's Hospital do that. They send their consultants here, there and everywhere to do clinics. Does that answer the question, Ruth?
Alexis, yeah.
I thought I could perhaps come in terms of the Scrutiny Committee question, particularly about local assurances, and it picks up a number of points that's been raised around how do we ensure continued democratic accountability and oversight. And what is part of our development of our local governance arrangements, and that includes building upon the successful arrangements we've had in terms of the Joint Commissioning Committee. One of my key ambitions is to continue to work with colleagues to look at, just to confirm and clarify the ongoing role of Scrutiny Committee, oversight by members, and also to ensure we've got that continued democratic accountability as we go forward, and to secure that into our local working arrangements. So that's a piece of work that is currently ongoing just now. And certainly, I've already committed to Lincoln to Bernard and to colleagues, out with this meeting. So I think it would be really helpful to have a further conversation, so that we're absolutely ensuring that we are providing assurances at a local level as far as we can do, and build it into our local governance arrangements.
So, yeah. Thank you, Alexis. So, Terry mentioned earlier the Health Wellbeing Board. Currently, the representation, as I understand it, is from the executive of the local authority, but not the scrutiny. Scrutiny function. I'm just wondering whether you want to respond to that now, or take that on board as part of the. Yeah, okay. Sorry, I've still got Gary. And Gary, you're only just visible where you are because of this this thing that's in front of me. Go on, Darren.
Thank you, Chair. I were waving, you know, but, you know, like you said, there's that big hump in front of you. Yes, thanks ever so much for coming and answering all the grilling you've had so far. It's interesting, you were saying there's no blueprint, and it's you know, we're on a level playing field now at ICS. I'm a LAC chair as well as Bernard, and it's Alan Hooper over there, Councillor Hooper over there. He's the north, I'm the northeast, and that's something I'm very passionate on, is GP surgeries and what's going off in our area and everything. So I'm not going to bore you to death on that. But there's just one point I want to try and squeeze out you, is when you were saying there's no privatisation, you know, and you know the staff. I think Ruth brought that up, and you know, if a GP surgery is owned by the GPs, is that privatisation? Now, have you got anything in plans now? Because I know a lot of GPs, family members as well, don't want to come into GP surgeries because they can't afford or don't want to buy that and have that responsibility. Are we going to take over all the doctors' surgeries and have properly all the staff from the ICS coming into that, or is that something what's still going to go on forever and a day? Thanks.
So, interesting question. It's been one that GPs have been debating for certainly as long as I've been involved in general practice. So it is to do with the contractual model. So you quite rightly point out that GP practices are partnerships between individual GPs. So, you know, their association of doing work in common makes them a partnership in law. The contract is to provide services on behalf of the NHS. So they're not quite organisations, but they're certainly not publicly owned organisations either. But they can only operate in the authorising environment of the public sector that their contract allows them to. Now, in terms of are we planning on kind of, if you like, consolidate, you know, kind of making an NHS-owned GP-led service in Sheffield or South Yorkshire? The answer is no at this stage. We would probably, you know, I don't know that necessarily it's the best approach. Firstly, I think my colleagues from the local medical committee would be able to furnish you with the pros and cons of models, but the partnership model itself does allow for a lot of innovation at community level. Once you kind of start getting into the NHS bureaucracy of, you know, almost a subsidiary unit of something else, it becomes problematic. We've seen that happen just down the road in Derbyshire. So a number of practices were struggling financially and struggling with their workforce, and the local hospital took them on. And they've essentially just become divisions, subsidiary divisions of the hospital, and their budgetary resource and so on is kind of consumed then into the hospital allocation and budget. So it is a difficult one, but as things are, there's no plans. But I'm very happy to pick up and have a lengthy debate with you about the pros and cons of that. You probably don't want to hear them all, but yeah, we're not headed in that direction. So there we go.
Bernard.
Yes, thank you for the continuing dialogue, which is great. I'm at this stage not convinced that the direction of travel is something that I would support, despite your reassurances. I think there's so many things that are very powerful forces out there that will skew this. I'm going to just pick up on the response about no impact on frontline staff. I was employed by the Sheffield Teaching Hospitals for 20 years. Frontline staff have witnessed numerous changes of policy, changes of plan, not only like the cleaning staff and people like myself, who are also a therapy assistant, working alongside professional physiotherapists, occupational therapists, what have you. I witnessed how disempowering that is. People are demoralised, and we're always aware that we were working in an organisation that was permanently unstable. As a frontline member of staff, yes, you do your job, you go and work with somebody who's got who's dyslexic, got dyspraxia. You do all that, but you feel all the time that you are out there on your own, and that any innovative ideas that you may develop as a team with the strengths of the certain people, the people around you, you're not able to influence that. And you're aware that your line manager, who is often very, very supportive, their neck is being breathed on by HR, who are being directed by senior executives within the trust. It's an awful, awful situation to be in, and people don't feel that the organisation is theirs anymore. Yes, it's very disempowering. So I don't feel that the model that's being pushed here is going to generate all that innovation that is so desperately needed. When somebody comes into a service, they are mostly unaware of the politics within the organisation. But I know full well how desperate a situation there is, because it stops staff talking to each other. It stops innovation at that level. And unions, although are helpful in many ways, they can't impact these sorts of arrangements. Even our HR staff are told, these are the rules, apply them. It's completely, they've got to follow the rules, otherwise they're in trouble themselves, they could lose their job. This is the sort of our organisation that is there at the moment. I really want an organisation that can empower the workforce so that they can bring their best to treating patients. So yes, as much as I'd love to believe you that the frontline staff are not going to be impacted, I think they're just going to further be demoralised by an organisation that can't listen because it's institutionally unable to respond to what's actually happening there. I'd love it to be different. I want it to be different, but I've not heard anything today that's persuaded me otherwise. Thank you.
So, am I okay to respond to that?
Absolutely, yeah.
I think they're really real concerns that you've raised. I think within a number of what we class as the provider organisations, there are concerns and certainly improvements that can be made around culture. However, I'm just going to pick this up just for the point of clarity, and this is not to downplay anything that you've said. And as a chair that came into a struggling organisation with a culture that was not viewed favourably from the outside world, absolutely I get that point around empowering staff, and I would hope that our staff now reflect that change in culture we've had within the CCG. So when we talk about frontline staff, I talk about frontline staff working in hospitals, working in GP surgeries, working in our mental health trusts, working in social care. The changes that are outlined for integrated care systems at this stage pertain to CCG staff. So the changes themselves with integrated care, in the course of time, you would hope there would be greater opportunities for instance, our teaching hospital to work more closely with our council to ensure that people aren't delayed on their discharge from hospital, or work more closely with mental health colleagues so that an individual on an acute medical ward having a heart attack can still have their mental health looked after. So those are the bits that we would like integration to bring over time. But in terms of talking to this paper about the HR framework, that HR framework only affects those staff employed by the clinical commissioning groups and by commissioning support units and some NHS England staff, none of whom directly interface with the general public. So my point of clarity for you is when I was mentioning frontline staff being affected by the HR changes, it isn't including those that work in hospitals. But absolutely, I get your point, and there's something here about culture within organisations, but additionally the culture of working together as a system. And I think we've still some development journey, putting that probably quite politely, there is still a journey for us to go on in Sheffield with our respective organisations. One would hope in the course of time, our accountable care partnership, or whatever it may be renamed in the future, should be bringing frontline care staff together to make decisions about things. And there are some areas where that's happened successfully. So we've seen some successful changes with mental health delivery through primary care networks across part of the city already. And that's very much been driven by clinicians, frontline staff, and indeed by patients. In addition to that, palliative care. So during the pandemic, we lost a huge number of people in our city who lived in care homes, who were elderly and vulnerable. And unfortunately, you see that bus coming, hurtling at full speed, and there's nothing you can do about it. But it was frontline clinicians, hospice workers, district nurses that actually came together and innovated. And it was actually their senior leaders having their back to get on and do that. And those are the types of cultural changes I would like to see integration bring. But I really, really do pick up on that point that actually, if you've got a very hierarchical culture within an organisation that doesn't pertain to empowering people or allowing them to do their things, then you're going to hit a brick wall. So just to summarise, my point about the HR framework not affecting frontline staff is to do with the transfer of employees from CCG to ICS. But I really do pick up on that point, and I think there is something for us as a partnership of NHS and social care organisations, and indeed voluntary community organisations and the public, to make a change there. That's probably goes slightly beyond the remit of this committee, so I'll stop talking there.
Yes, do you want to add, Alexis? Yeah.
Thank you very much for the question and also the insights that you've provided into the impact on frontline staff. And I think what you're describing is very much is not only the cultural shifts, but also the how we take forward and co-design change at a practitioner operational level. And sometimes, and I've been part of many integration journeys over the years, I would say, is that often it's easy to get caught up in talking about the policy, the strategy, the governance, but actually forget about what does this mean to Mr. and Mrs. Smith and communities, what does this mean to our frontline therapists, our frontline staff, and whatnot. And that's where, one of the key things I talked about at advice today was my own priority coming into post was about very much focusing on co-design and co-development. So we're absolutely thinking about how we ensure that we are taking that principle into everything that we do, because that principle is about the culture shifts and empowering our workforce and empowering a different set of conversations and taking that forward. So from my perspective, obviously, I work for Sheffield City Council, so but what I can do is perhaps take on board and perhaps speak to you with the meeting to gain further the information and share that with colleagues as to how we could build that into our arrangements and going forward. That makes sense.
Okay. I've got no one else indicated. I'm going to try and pull this together now. I'll bring Emily in at this point, I think.
I've tried, as you've been discussing, I've tried to kind of pull out the key points that have been a theme through the discussion that you might want to put to the CCG to take away to consider as the ICS develops. Those were concern that the development of the ICS will lead to increased privatisation and seeking assurance that there won't be private providers sitting on ICS boards. The importance of hearing seldom heard voices in service redesign, keen to maximise opportunities around the development of the ICS might bring around our carbon ambitions, the importance of involvement with LACs, the importance of local accountability and ensuring that changes aren't that empower staff rather than are detrimental to frontline staff. I don't know, does that feel like it covers the key issues that you've discussed today?
Yeah, I've got any members to ask. I know that there was a point made right at the start. I think it was Aptistan about the, I can't remember whether it's Aptistan or not, about the potential for distraction and disruption, because we as an authority are going through a governance transition period. Here's the health authority, the health service going through a major transition here, and I think the point wasn't it, I can't remember whether it's Apsan or not, but it struck me that there is potential for quite that to have a negative impact on the delivery of health services, which we are here to scrutinise. And also a major point, I think, for me is I do have concerns over the legislation, but perhaps we can use the opportunity to feed that through the Centre for Governance Scrutiny when they have the session, the committee stage evidence giving session there. Accountability to local people, because currently the powers that this scrutiny committee, all scrutiny, health scrutiny overview committees have, allow us to ask or to challenge, currently through the CCG processes, any sort of reconfiguration, those kinds of issues. With currently as Emily said at the start, with the powers to refer to the Secretary of State if we were, that dissatisfied with the reconfiguration. Seems as though the way that the legislation is worded is that we won't have some of those powers, and naturally we're concerned about the ability for us to scrutinise on behalf of Sheffield people rather than South Yorkshire people. So I think that's quite important. I'll let you comment on that.
This is a comment rather than a concrete fact. Within the, and I think it's the, I apologise because there's about 20 different documents NHS England have published and there are more on the way, but I believe it's in the interim guidance for governance of ICSs. Within there's a table that outlines all of the statutory responsibilities and statutory obligations of clinical commissioning groups that will transfer to the ICS. Now, there are about 120 of them, all with their own laws, and I haven't taken the detail to memorise them all, unfortunately. But whichever statutory obligation the CCG has that pertains to answering to scrutiny committees will be outlined there. And if that is something that transfers into the new ICS, then one would assume that that obligation continues into the new body. So it's just a tip there. I'm probably looking at Emily here, but you might want to have a good read through that document and see if you can find out the relevant section and relevant act that relates to that. It might help answer your question.
Right. Okay. Bernard, yeah.
Thank you, Steve. There were two, Councillor Steve. There were two issues that you missed out there. I feel that the ethical procurement, that process, and also the lack of public health within this structure. Thank you.
Yeah, thank you, Bernard. We've taken, Emily's added those, yeah. So, try and pull this all together. We have a set of recommendations that have been put before us. I take on board comments that Bernard and certainly I know I and other members have about the overall, you know, the overall principle of this. However, we are where we are, and I'm just wondering how I'll hand it over to members on these. So if I could go through the recommendations, and if you aren't happy, want to amend, we note and update the developments. I don't think anybody's got any problem with that point. Give support for the direction of travel for the ICS. I'll put that over to members. I mean, is there a move to not accept that recommendation? There doesn't seem to be.
Could it be
Ruth,
put?
come on, help me out.
May we add something to that? Just to reflect on some of the things we've discussed today, which relate to the direction of travel in terms of public engagement, workforce protection, and the sort of green infrastructure. I don't know if is it possible to append something to to that statement rather than just giving support.
Advice from the experts. Yeah, do you want to say that, Emily? Yeah, rather than repeat it all.
One option would be to just note the update in the developments and then ask the CCG to take on board the key issues that you've talked about today. The list we gave earlier that Councillor Nelson's alluded to there, the ethical procurement, public health, concern over privatisation, carbon ambitions, involvement with LACs, the list we went through earlier, and to take that on board in discussions on ICS development going forward. And just kind of leave it at that.
Yeah, so that would really apply. Has everybody followed that, and is everybody happy with that? Okay, yeah.
I'll put that into a more formal form of words for the minutes and to circulate to the CCG.
Okay, so I think that draws it to a close. So can I thank Terry for your time in I mean, you weren't originally the person to come and face all this flat, weren't you? So thank you very much for that, and thank you for Alexis for for coming along today. So I think that's it. So can I bring the meeting to a close and thank everyone for their input? I think it's it's quite significant. It's a significant issue, and I thank you for that. Terry, yes, yeah.
So thank you, and if you ever join one of my governing bodies, unfortunately I always get the last word, so I apologise in advance. I think, as I've mentioned already, this is part of a developmental journey, so I really welcome those comments that we can feed back into system design, but also just a bit of a plea here that it isn't over yet and it's not finished. So I've really welcomed the opportunity to come and discuss this with you today, but please can we keep the dialogue open so that we can successfully design something that actually serves people in Sheffield to the best of its ability, rather than us kind of get 6 months down the line and boom, here's the plan and we don't quite like it. So I'm committed to continuing dialogue, and I'd hope the door's open. Please contact me, and if you need us back at committee at any point in the future, please invite.
I'm grateful